Now we're turning to another excellent panel where we're talking about a fundamental issue here, which is access to care and meeting our warriors where they are. Leading the session will be Dr. Aditi Malik from the Centers for Medicare and Medicaid Services. And joining her on stage are Captain Darren Burton, Division of Blood Disorders and Public Health Genomics at the Centers for Disease Control and Prevention, Ms. Mandy David, Maternal and Child Health Bureau with the Health Resources and Service Administration, Mr. Tristan Lee, warrior, model, and actor from Williamsport, Pennsylvania, and Ms. Ashley Valentine, co-founder and president of Sickle Cells, which is an awesome name, a policy-focused sickle cell disease community-based organization based in Chicago. Please join me in giving them a very warm welcome.
Good morning, everyone. We're the last panel before lunch, so we don't take that lightly. Thank you for joining today's summit. My name is Dr. Aditi Malik. I'm the Director of Clinical Strategy at the Centers for Medicare and Medicaid Services, or CMS, here at HHS. As you just heard, the panel we're about to talk about now is about advancements in access to care. I'd like to start by sharing a bit about what we've been up to at CMS, and then we'll go down the line with each of my amazing co-panelists here, sharing a bit about the work that they've been up to from their vantage point before we get into some discussion. As we reflect on Sickle Cell Awareness Month, we at CMS really want to affirm our commitment to everyone in this room, to everyone living with sickle cell disease. As Secretary Becerra mentioned earlier, the vast majority of people with sickle cell disease who have health insurance coverage are insured through Medicaid, the Children's Health Insurance Program, or CHIP, or Medicare. So really quite important to CMS from an access to care perspective. And as others have reflected on today, and I certainly know from my experience caring for patients in the hospital and in the ICU, there are many challenges that people with sickle cell disease unfortunately still face in accessing care. Last September, CMS released a sickle cell disease action plan that outlines what we are doing across all of our levers in policy and quality and payment, billing, coding, reimbursement, to really help ensure that folks with sickle cell disease have access to the comprehensive care that they need. That action plan, I encourage you to look it up. That action plan includes 4 key focus areas. 1 is expanding coverage and access. 2, improving quality and the continuum of care. 3, advancing equity and engagement. And 4, examining data and analytics. And as you'll see outlined in that plan whenever you have a chance to take a look at it, we're focused on things like ensuring folks have continuity of healthcare coverage with respect to potential lapses in coverage, improvements in clinical quality measurement, telehealth, making sure that folks have access to and that providers get reimbursed for good chronic pain management, reproductive health, and many other areas. And as you also heard Secretary Becerra mention earlier, we are working on a new model through the CMS Innovation Center to improve access to sickle cell disease gene therapy for Medicaid enrollees. Lastly, I'm excited to share, and this was noted in the toolkit that was released last year, that by the end of this year, we plan to release a sickle cell disease clinician provider toolkit that's designed to serve as a one-stop shop resource for the array of CMS resources and programs and policies, including billing and payment, which we hear quite a bit about, for services and supports for comprehensive sickle cell disease. With that, I'd like to take the opportunity to now bring into the conversation my wonderful panelists. We all decided in advance that we're going to call each other by our first names, just for consistency's sake. So Mandy, I'll turn it to you to share a bit about your work at HRSA.
Thank you so much. Good afternoon, everyone. Good morning still, right? Good morning. All right. So my name is Mandy David. I am here on behalf of the Health Resources and Services Administration under the Maternal and Child Health Bureau and the Division of Children and Youth with Special Health Care Needs. I'm delighted to be here. I am a public servant, as we all are, here for those living with sickle cell disease. I'm also a clinician, a physician assistant of 20 years. So I'm just going to give a little snapshot of our program. If you can envision a triangle, in one corner we have our long-standing demonstration program. This is comprised of 5 comprehensive sickle cell centers around the country. They offer comprehensive sickle cell services, which, as you know, is rare. And these are in big institutions, and they offer a lot of clinical services to people who live with sickle cell disease. They also serve as mentors to other smaller clinical sites as well. On the other corner of our triangle, we have 25 community-based organizations. They are a newer piece of this triangle, but not that new. The reason they're new is because we're now directly funding them. Initially, we always partnered with them. We did work. They were always referring patients into the system of care, as they have done historically forever. But now HRSA has decided to directly fund 25 community-based organizations, and they are working together with the demonstration program. And then last but not least, we have our coordinating center at the other side of this triangle, the last corner. They keep everything running. They have all the meetings. They facilitate things like our community health worker training. We have a community health worker sickle cell disease-based training that happens throughout the year. And so we know that we don't have enough benign hematologists, we don't have enough providers, but we do have people that are willing to be community health workers that can reach out and walk into these communities and help these patients get into care. So, as you can see, our model is an access to care model. We are all about getting patients into care, but we are all about directly funding all of these components in this triangle to make sure that they have since they have the boots on the ground, that they are bringing patients into the care that they need, the comprehensive care, not just any care, but comprehensive sickle cell disease-based care. Thank you.
Thanks, Mandy. Darren, can I turn it to you?
All right, thank you. So I'm Darren Burton, and I serve as the Director of the Division of Blood Disorders and Public Health Genomics at CDC. And I am happy to be here to share with you about CDC's Sickle Cell Data Collection Program, and specifically how the program is used to improve access to care for the sickle cell community. Now, before I talk about what the program is and how it works, I want to take a step back and provide some context for why a data collection system like this is needed. So we've heard, and we all know, that sickle cell warriors and their families can experience a lot of challenges, a lot of barriers in accessing comprehensive, specialized sickle cell care, which is so important for protecting their health and helping them to thrive. And one barrier that unfortunately a lot of warriors face is distance. So if you have to drive or take public transportation for hours to reach the nearest sickle cell provider, that can be a huge barrier to receiving the right care. But unfortunately, the state and healthcare providers often don't know how many sickle cell warriors are unable to access appropriate care because of distance. As you might imagine, healthcare systems typically have information on the patients who are able to access care, but they don't know who they're missing. And to really have that full picture, you need to have strong data collection infrastructure, as well as strong collaborations between the sickle cell community, healthcare providers, the state, community-based organizations, and other partners all working together. And that is exactly what CDC's Sickle Cell Data Collection Program does. So the goal of the program is to include all persons with sickle cell disease in the data collection system, regardless of their age or severity of illness or their insurance status or where they receive their care. And to do that, we put together several sources of information that are existing sources on persons with sickle cell disease in the US. Some of the core data sources that our programs use are statewide all-payer hospital and emergency department claims data, Medicaid claims data, newborn screening data, and also information from some of the larger sickle cell care clinics. So CDC and our partners have been doing this data collection work since 2010, and initially the work was all funded through partnerships. And after early successes laying the foundation for how to do this work, we were able to officially launch the Sickle Cell Data Collection Program, as we now know it, in 2015 with just 2 states. With additional funding, we were able to grow the program to 11 states in 2020, and CDC received congressional appropriations for sickle cell in fiscal year 2021. So as of now, we have 16 states participating in the program, and we estimate that the program covers about 50% of the population with sickle cell disease in the US. So that's a little bit about the need for the program and how it works. I will close with 2 success stories, which are examples of how the data from the program can directly be used to improve access to care for the community. The first example is from California, which is one of our inaugural states in the program. I see back there, we see California in the house. And California's data was able to show that more than 30% of the sickle cell population in California resides in just one county, which is LA County. But unfortunately, the only adult sickle cell clinic in that county closed in 2009. So sickle cell warriors in that community were having to drive long distances, or adults with sickle cell were more often needing to receive their care in the emergency department. So advocates and partners were able to use these data to educate policymakers about the really urgent need for improved access to care in this area. And as a result, a new adult sickle cell clinic was opened in South Central Los Angeles. The second example I'll give is from Georgia, which is our other inaugural state in our program. And their data showed that almost 25% of the newborns born in Georgia with sickle cell disease lived more than 1 hour's drive from the nearest sickle cell specialist with daily service. So in Georgia, these data are being used to inform additional care models, including where sickle cell clinics are placed, telehealth services, and mobile services. So these success stories really demonstrate that robust data collection combined with strong partnerships really can move the needle on access to care for the sickle cell community. And we are committed and excited to continue these successes and really extend these successes as we go forward with our partners. I'll stop there. Thank you.
Thank you. Tristan.
Hello, my name is Tristan Lee. I am a professional model. I'm an actor. I am also a fashion designer with the line for sickle cell disease awareness called Devo Stars. And I'm also a professional patient advocate with Sickle Cells and the SCDA, and just, other sickle cell orgs that need me. I'm always there to help. So my story is that as a sickle cell patient, I was diagnosed at 6 months. I live in Williamsport, Pennsylvania. I don't know if any of you know where Williamsport, Pennsylvania is, but I always say, do you know Little League? Like Little League World Series that just passed? That's where I'm at. So Williamsport, Pennsylvania is a very small city, and I was the second person in the city to be diagnosed with sickle cell type SS back in 1983. Currently, I am one of, I believe, 10 that live in the city, but unfortunately, the hospital that is there does not have the proper tools to, help sickle cell warriors, and that's where I come in, and my mom comes in. We advocate with the ER all the time. We had them pass a policy, 15 minutes or less when you come in, any sickle cell warrior, because we know that can cause organ damage. So we made sure that every sickle cell warrior that comes in through the doors is seen within 15 minutes or less, because there was long wait times and it just was unacceptable. So going back to when I was diagnosed at 6 months, and doctors told my mom that I would not live past 20. By the grace of God, I made it to 41 today. Well, in June. And it's been a roller coaster getting to this point. So after I was diagnosed, we had a lot of pain crises up until the age of 9. So I was constantly in and out of the hospital. And then at the age of 9, I suffered a stroke, which left me paralyzed on the left side of my body. But the stroke could have been avoided, I feel, because the hospital that I was at, as I said, that I'm in the town of, didn't have the proper tools and know how to take care of me. So they had to send me in an ambulance 45 minutes to another hospital, which was in Danville, Pennsylvania. And that hospital had the know-how and the knowledge, but even that 45 minutes that I rode in the ambulance kind of took a lot, you know what I mean? So in that course of time, on the way to the hospital, we think that, the stroke could have been avoided, but unfortunately, the hospital that I was at didn't have the tools, so I got transferred there. I stayed in that hospital for 6 months. I had to relearn to walk, how to talk, use the bathroom, and do everyday things. So after I got out of there, I went back to school, and I was feeling very low and depressed and almost like a little suicidal. So my mom pulled me out of that by letting me know that there was an acting company that was coming through our city and asked me if I wanted to audition, because she knew when I got on stage, I lit up. So I was like, yeah, I'll try it. So I auditioned, and yeah, I got on stage, I lit up, and people were looking at me, not because of the way I present and show up, but because of my talent. And that put me on a trajectory for the rest of my life. I was like, I want to do this because it honestly saved my life. So I got into acting, I got into modeling. With modeling, I learned how to, hold my posture right. I learned how to talk through acting classes and voice classes. It really helped with my speech. And so after that, I was being seen because I was in Harrisburg, Pennsylvania, taking my model classes, and that's where our CBO is. And they discovered me, and they were like, hey, we think that you'd be perfect to be one of the speakers at one of our upcoming summits. And I was like, okay, I've never done that before, but I'll try it. And so we spoke on the Capitol of Harrisburg, and then I went in and spoke to senators about the disease. And from that point on, I became a sickle cell advocate. So I was like, I love this, you know what I mean? If I can help anybody learn about sickle cell, I am down. If I can help save lives for sickle cell, I am down. Like, this is why God put me here and why I survived this stroke, and that is why I'm here today. Thank you. So that put me on a huge trajectory, and I still to this day advocate with that CBO, as well as other CBOs. But the importance, and I'm trying to express, is that, it was just such a detriment, I feel, that me living in the city that I am, I was basically in an area that didn't have the knowledge to take care and handle sickle cell. Like, we don't have any sickle cell clinics. We don't have any kind of sickle cell, really, like, doctors. I now see a hematologist at a cancer treatment center every month, which I've been taken very well care of. I have a great care team, but again, they don't have a specific sickle cell center, and that's what I'm advocating for to this day, because I lived in Georgia, and when I was in Atlanta, Georgia, there's so many things that go on in Atlanta, Georgia, and one of the things I really found was their sickle cell community out there is amazing, and they have, sickle cell spas, they have sickle cell day treatment centers, and all that, and I was like, if I could get this back in my hometown, not only for me, but for the warriors coming behind me, and everybody with sickle cell behind me, like, this would be a huge game changer. So that is why I advocate, and that is why I'm here speaking on that. Williamsport is also 3.5 hours away from every big city. So, like, I'm 3.5 hours away from New York, I'm 3.5 hours away from Philadelphia, where I also had to go to the Children's Hospital of Philadelphia every 6 months to see Dr. Frimpong. Yes, Dr. Frimpong, may he rest in peace. And he took very well care of me, but again, that was such a distance and a drive, you know what I mean? So that was like, it cost my family going back and forth. Sometimes we had to, just travel for the day and come right back. So it was just one of those things. If I had it in my town, or if they had it in their town, we could just go, get it done, and then go home and rest and do us, you know what I mean? So that's why I'm here speaking about sickle cell and making everybody aware that, the access and care in small towns and small cities where there are many sickle cell warriors like me need attention and need, treatment and deserve the same kind of treatment as, like, the bigger cities. Yeah. Thank you. Ashley?
You know, before our prep call, David did talk to me and Tristan, said we had to behave, because me and Tristan both were like, we've never been on a panel together. Wouldn't that be fun?
And we cut up.
We did. So I'm Ashley Valentine. I'm also known as Marcus Valentine's little sister. So there are some people here that don't know me. So I am a co-founder and president of Sickle Cells. We're a national sickle cell disease advocacy organization. But the other co-founder is my late and great brother, Marcus Valentine, who Tristan also got to know. And Marcus would be the same age as Tristan today if he was still here. So my brother lived to 36 years old, but he had this vision that everyone in the sickle cell disease space needed to receive the same access to care that he did. And it was the story that made the difference. And so the people telling that story were not only my brother, but it was my parents. So there are lots of sickle cell parents, and I really want to shout out some of our sickle cell moms. Specifically, there's Tristan's mom right back there. Hi, Miss Debbie. My mom took it upon herself to be a nurse, to learn everything about sickle cell disease that was necessary. And when Marcus had that bumpy transition between peds to adult care, she went ahead and chose his adult care team. For the doctors that trained underneath her as fellows then became his hematology team, and he was the first sickle cell patient in our suburban hospital. So through their advocacy, they were able to pave the way for the other sickle cell people to come into his hospital. But what they taught me is that power of that story is what really makes the change happen. So Sickle Cells was founded in 2017 off of a favor that I did for my brother. He said, Ashley, you know, I'm sick. I can't run as fast as you. Can you help me out? Because we really have to make a change. And I said, sure, but only for a year. So here we are, all these years later, and I just want to say thank you so much to HHS for having this event. We've come so far, and this community deserves every bit of what's happening right now. So this panel is about access, and what I'm here to do is talk a little bit about what the community voice looks like in the realm of access and what Sickle Cells does. So part of the storytelling is for us to really quantify that patient voice, but it's really to connect the person living with sickle cell disease to that decision maker. And so I wrote down 3 examples in this little notebook here that I got last week at the Cayenne Wellness event, because I don't want to forget about it. But what we've heard other remarks discuss is the cost of sickle cell disease treatments, the current treatments. So a lot of the work that Sickle Cells does is talk about the real cost. We know that in the sickle cell space, a lot of what we do is not gather the data because there's not funding. And so we put our head down and we do the work. But when it comes to setting drug prices, deciding if payers are going to pay for them, writing laws, passing bills, what counts as data is not necessarily what we know as individuals, but what counts as data is what's published. So part of the work that we do with Sickle Cells is we lead some of this community participatory research so that we can start to give real numbers of what it costs to take care of people with sickle cell disease. So one major example that many of you were involved in was that My Life with Sickle Cell Disease study back in 2020. And that was a result of the Institute for Clinical and Economic Review because of those 2 drugs that were approved in 2019, the Adakveo and the Oxbryta. But what that study did, and it's still standing, the only community participatory research that really takes into consideration how much people cost who have sickle cell disease. So we interview caregivers. How much work are you missing as a caregiver? How much out of pocket are you spending to supplement the cost of treatments as a caregiver? And we looked at caregivers for not just children with sickle cell disease, but someone that is involved over the course of a lifetime. And so that study is still so important because that study was also used in the present day ICER review when we were talking about the cost for the gene therapies. Now, this seems counterintuitive, but I want to explain this. Because of that research, the first pass at the price of the gene therapies was actually lower than what the prices are set now. And why that actually is a positive is because without our voices, the true cost of sickle cell disease was not captured. And so it meant that the original price undervalued those treatments. So what that means is that when, there's companies, when the agencies, et cetera, are setting prices, they actually don't know how expensive it is to take care of us with sickle cell disease. So when we actually put all of that together, we know in data it costs the system nearly $3 billion a year to take care of us with sickle cell disease. And what's not captured, though, is exactly what Tristan here explained, that drive all the way to Philadelphia. But what's also involved in that drive means missing school, missing work. If you have other kids, they also have to get pulled from school. The cost of food when you go to that trip, all of that, those are the types of costs that we try to capture, and if we can't capture it quantitatively, we try to make sure that that person with sickle cell is in front of that decision maker so they can explain that story. The other two examples I want to highlight here is that some of you know us from working at the state level at those review boards for Medicaid, so the Drug Utilization Review Board meetings, the Pharmacy and Therapeutic Review Board meetings. So each Medicaid has a review board, and those members decide if a treatment is covered on the formulary or not, if it's preferred or not. So many of those review boards had never heard of sickle cell, and someone explained to me that you don't really know about a disease in the payer world until you have to start paying for it. So they didn't actually know they had been paying for us all this time because we weren't reflective in the data. But with the approval of the high-priced drugs, as they call them, or the specialty drugs, or the drugs, in my opinion, are actually more affordable than taking care of for someone without them, then they actually started to care. So what we did was we learned about these meetings, and we would tap sickle cell advocates and try to prep them to go testify. And so a case study, what this looks like, is in Illinois. So in 2021, there was an Illinois DERB meeting, and this Illinois Review Board was reviewing Adakveo. Sorry, they were reviewing Oxbryta. So Sickle Cells was able to pull 7 individuals. We pulled the Sickle Cell Association of Illinois. We had providers from La Rabida, from UIC, from University of Chicago, social workers, and they all testified, and the meeting was virtual, and that was the first time state Medicaid had ever heard from that many people about sickle cell. So the outcome was that they had another meeting in 2022 that was then re-reviewing that first meeting. And then in 2023, they specifically had a sickle cell meeting. And in 2024, Illinois is one of the first states to have a sickle cell specific committee that the governor appointed to look at the gene therapies at the state level. So all of that is a clear example of what advocacy with the story does and the outcome there. So another quick example, because I only have 5 minutes, is a result of that ICER review, Premera Blue Cross Blue Shield. They're located in Washington, and they came to us and they said, we had no idea sickle cell was like this, and we cover a lot of people with sickle cell. And I said, why? And they said, because they cover Amazon. Well, they went ahead and they changed their opioid policies to match the cancer policies because they just didn't know. And we also discussed with them, thank you so much for doing that. Can you please review all your other policies? So I don't quite know the outcomes of that because that's proprietary. But what you'll see here is your voice really is important. And so our role at Sickle Cells here is to find these opportunities and simply just show you where they are as the advocates. And so the last thing I want to say is we've talked about the cell and gene therapy model, and that is very exciting here. And I want to give a shout out to Mariah Scott, who's now known as Professor Scott. You'll see from her later. There she is. So a lot of what we did in this model was quite literally bring the community voice to the decision makers, which in this case was CMMI or CMS as well. And as a result here, oh, I lost my train of thought, you guys. I'm so sorry. I was excited about Mariah. Mariah's work. What Mariah did was we encouraged Medicaid to participate. So Mariah went ahead and reached out to all 50 state Medicaid directors with data about sickle cell disease, with the stories from the community, with the names of the CBOs that were in their states. And we got some interesting results. There were states like Utah that were so excited to meet with us, and they wanted to know who in their state had sickle cell and where could they learn from. And why I bring up that example is because we were expecting some of the other states, Maryland, California, Georgia, to reach out to us, but it was the people that we least expected, Utah, that have 42 sickle cell patients on Medicaid, say, we really want to take care of our people. Can you tell us their story? So I can stop there, and I'm really happy to be here.
Thank you all. Just another round of applause for the 4 people that I get to share the stage with. So with all of that background, a few questions for everybody about access to care. One of the themes that we heard again and again was the difficulty in transitioning care from pediatric to adulthood, adult to older adult. And I'm wondering if, and this is a question for all of you, reflect on how we can make those transitions as seamless as possible to make sure that folks have access to high quality care.
So I think, because I have been through this, going from pediatric care to adult care in sickle cell, I feel like that, and I worked as a professional patients what was it called? I was helping kids transition from pediatric care to adult care. So I was a mentor for these mentees. So when I told them when I was transitioning from pediatric care to adult care in my little community, that I would keep like a little notebook with 5 things in it. And you always want these 5 things on you, and that is, you always want your blood type, you always want the type of sickle cell that you have, you always want your medications, and you always want like an emergency contact, and you always want them to know like your allergies and all that stuff, because a lot of times when we're in sickle cell crisis, it's just, if you don't have somebody with you to speak for you, then they need to be able to reach in your pocket, pull that out, and know your situation. So I told them they always carry that. And so when it was my time to transition, I looked at my doctor and he was like, well, I feel like we can take you from, you've been seeing us every 3 weeks after your stroke, getting blood transfusions, and you've been doing pretty good. But now I feel like we can take you, since you're an adult, and put you to every 6 months. And I was like, I don't think that's going to work for me. So I really had to, at that point, stand up and be my own advocate, since I realized I was an adult at this point. So I was like, well, I hear what you're saying, but how about if I still continue to come every month, do my blood work, get my levels, and you see me, and we just work it out like that. And so from 19 until today, my doctor thankfully listened to me, and I've been doing that every month, and my levels are well. I'm living well with sickle cell. You know what I mean? I haven't had any crisis since 2016 by the grace of God. And so it's so important for our young adults that are transitioning to know that they have to advocate for themselves, because in pediatrics, you're very well taken care of, right? But in adult care, you kind of get lost in the shuffle. And if you're so used to something and your health care being what it was as a pediatric case, then you want that same adult care, you know what I mean, transition, and you have to advocate for yourself to make sure, don't let them tell you, you tell them, and then you guys work it out together. And it's always about open communication. I always tell people that, and I always tell my mentees that, like, just make sure you have an open communication and just go from there, and you should be beautiful. If not, I'm always here. I know many other advocates in all areas, all states, and I can always connect you. And that's a real way to make sure that we have that perfect transition so that we don't lose, anyone from the pediatric side into adult care, and nobody gets lost in the shuffle, and we all continue to live well and do us with sickle cell.
Yeah, we can clap. Thank you, Tristan. So at HRSA, our goal is to make sure that every kid with sickle cell disease can play, go to work eventually, and grow into a healthy adult. But as you all know, that takes a lot of steps. There are a lot of challenges. Our grantees, I'm going to start with our community-based organizations. They actually have transition navigators where you are assigned cohorts of community health workers who are making sure that once the intake has happened and you're a teenager, that you are followed all the way to having a successful appointment in the adult side. We also have a workforce issue, right? And a lot of people don't contribute that the transition issues are also related to workforce. Who we transition them to? Where are they, right? And so we talk about telehealth and all of that, but really when you need to see someone, you need to be able to know that they are transitioned to a stable, comprehensive, sickle cell, high quality, how many more adjectives can we add? Disease plan and team. And so we have the support program, which stands for Sickle Cell Disease Advanced Practice Providers, Opportunities, Resources, and Training. They're training cohorts of APPs, nurse practitioners and physician assistants. They're training community health workers. I think I talked about our coordinating center who's actually training community health workers. We're not just training community health workers, we are training them to be sickle cell disease-based community health workers. There is a difference. Not every type of community health worker can be in every discipline. And so you have to teach them the social determinants of health of the people that are affected by this disease. And so they can go into these communities and understand them and make sure that they build that trust so that they can say, look, you can trust me. Here's an adult provider. We also have transition plans. And obviously, last but definitely not least, our providers who have been in this space for over 20 years, a part of our demonstration program. We have pediatricians, we have lifespan docs, and we have adult providers. And they all work together. People forget that also going to college is a transition. And so they talk to each other and they connect with each other. And so we have a network of providers, we have a network of CBO plans and navigators that all work together, all 30 of them, to make sure that these patients, to the best of our ability, not only are in care, but stay in care through adulthood.
Thank you. I'm going to close this out with one last question for everybody, and Ashley, this will pick up on the theme that you brought up around bringing voices to the forefront and really the importance of that in conversations like this one. So question for all of you, in any order that you like, your thoughts and reflections on best practices or approaches to make sure that the community voice, the individual voice, the person with lived experience, parents, caregivers, patients, is really brought to the forefront in policy and programs.
Yeah, I can take that. I do want to preference by saying my brother and I were violinists, and our violin teacher told us if she had no comment for us, it means we weren't ready, we weren't prepared, we didn't show up prepared. If she had comments for us, it means that we practiced and we were here. So I say that because there's a lot of very good work going on here at HHS, at CMH, HRSA. So I have comments. I think the best way to make sure that community is involved is to make it a requirement. So a best practice is FDA. It is required for those committee meetings to have public comment, and it's required that everyone with public comment has a certain amount of time. The CGT model doesn't make it a requirement for community to be involved. It's an option. It's an option for states to work with CBOs. It's an option for the companies that are working on the contracts to work with community. It's an option. So it's up to the states to decide if it's worth it or if it's necessary to work with community. And a lot of our job is making that case, showing them what they don't know so that they say, oh, we probably should invest money into this because ultimately it saves us money to work with the sickle cell community. So I do think the best way to make sure that there's quality care is to make it a requirement and to make it penalties if you don't face those requirements. The best way to make sure the community voice is involved is to make it mandatory, to make it required, and then also to ensure that there's proper and appropriate compensation for those people that are working from the community level.
I can just add also from the standpoint of our sickle cell data collection program, we really want the data to be used, to be actionable, to improve health and outcomes for the sickle cell community. And the best way to do that is to make sure that the community's voices are baked in, built in, guiding the work from the beginning. So in each of our states that participate in the program, the teams orchestrating the data collection include researchers and clinicians, but also community-based organizations, warriors and their families. And this way we make sure that we're using the data to address the questions that actually matter and are going to lead to those success stories.
That was great answers. I think that it's important always to listen to the patient or the warrior, as I like to call them. You know, they're going to be your first and foremost source to go to know and understand, like, what's needed, what might be missing or lacking. And I feel like a lot of times doctors sometimes won't actually hear the warrior. They'll kind of just plot out the plan for them, and we're just supposed to go with it. But I feel like an open communication, like a back and forth, is what's needed. And that way, you know, everybody is heard and brought to the table, and then we can all move forward together. And I think that's the best way going forward.
Okay, sorry, what was the question again? Oh, yeah, community voice. Okay, so sorry, it's lunchtime, right? All right, so the community voice, HRSA is very intentional about this. I've been here for about 3 years. Before I was a clinician and had to put my community-based hat on, and I appreciate all the grantees because they've taught me so much about community work. But what they've also taught me is kind of embedded in our blueprint, which is we have to measure what matters. And we don't know what matters unless the community voice is at the table. And so that we also collect data. We collect data on lived experience and people who have sickle cell disease and are part of your advisory boards and things like that. So, you know, it's hard to put into words because it doesn't. It's kind of scientific. It is opinionated until you have someone sitting at the table. And because we work with 25 community-based organizations, we have heard so much through what we collect from their data, through having them a part of all agendas at our annual meetings. The community voice has kind of changed the way we do our work. It has changed the way we look at data. It has changed the way, like, are we telling a narrative, are we telling it from one perspective? Are we telling it from everyone's perspective, including the community? So I can't emphasize enough how much we have learned, how much we have evolved from just allowing them to say their piece of the puzzle, because they are like a key part of the puzzle. Thank you.
Thank you. One last round of applause for our panelists, please. Thank you. With that, we'll turn it back to our MC. Thank you very much.
Thank you.
Thank you so much. Have a blessed day.
Fantastic. Thank you. One more round of applause for that panel. That was fantastic. So earlier this morning, Secretary Becerra announced a very critical update on the Social Security Administration. Now with some very brief remarks, because we know we're keeping you from lunch, is Michael Goldstein, Director of the Office of Medical Policy at the Social Security Administration.
Hi. Thank you. I've never been a special guest speaker before, so I am honored to be here today, and I know we're up against lunch, and I don't want to keep that too long, but I do want to say that we are really grateful to be here with you today. I'm grateful that Dr. Wong asked me to come and give a few remarks, and I can tell you a bit about some of our recent work. I'm grateful for the collaboration that we've had just this past year with HHS. And we've got a great team of folks, of technical experts from our Office of Medical Policy here, listening and learning from you all today. We also have one of our senior advisors, Ben Belton, from the Commissioner's office, from Commissioner O'Malley's office, who's here with us today. So again, just so grateful. Secretary Becerra did note this, and it might seem like a small thing, but it really isn't to us, because we know we've heard you all, and I think the point is that we want to bring this to you today to show you that we've heard you. We understand that it can be really difficult going through the disability application process, right? So in the short term, we are releasing tools like this one. This is the adult guide specific to sickle cell disease and the disability evaluation process, right? And as the Secretary stated, there isn't one of these for any other impairment. This is the first one of these we've ever done, right? And that was because we did hear you, and we've worked with our colleagues. So I'm proud to be involved in that. I'm especially proud of my team who put in all the legwork to make it happen. Beyond that, in a couple weeks, there's going to be a childhood version of this, right? So I don't know how many of you follow Social Security on social media, but that's, I don't know. I'm not a big social media person, but I imagine that's like not the top Instagram channel. But anyways, so please keep an eye out. That's going live today. I told them to please start releasing this. Literally, these were printed yesterday. It says September 2024 on them. That's hitting the internet today. So please look out for that. A few weeks from now, the childhood version is coming out, We're also going to release some additional materials, including for the practitioners out there, a desk guide of sorts for medical professionals, right, to help them understand what we need, because sometimes our disability process isn't always exactly aligned with care that's received in doctors' offices, right? So that should be really helpful. We're going to engage in training and other related materials for our adjudicators in the near future. And I also did want to touch on one other piece, and that's in the long term. We've heard concerns about our rules specific to sickle cell disease. So we have invested significantly, and a couple of our partners are here today. I don't know where they're sitting, from the national academies. So we have made a significant investment, and we have started a consensus committee, which will include top experts throughout the nation on sickle cell disease and beyond, to look at some of our specific rules related to sickle cell disease. I think that should be welcome news for everybody, but I'm really giving it a plug to the practitioners, and I've got to meet a few of you in a couple different outlets over the last several months, and I hope to continue to meet you all. But that call for experts is open until September 30th for those that practice in this area or are involved in advocacy. So I encourage you to check that out. So that's the National Academies of Science, Engineering, and Medicine. The consensus study for sickle cell disease. I think you should be able to find it. I can help you if you want to approach me, and you can't. But please look for the guides online. I do have some copies. I don't have enough for everybody, but if you are particularly interested in disability, the application process, come see me. We have some, but it would be also great for people just to Google it and hit it, and we'll get that URL out there, because I think, again, no internet expert, but I think the more people that access it, the higher at the top it'll be of the Google list. So anyways, maybe someone can correct all my technological errors. But thank you so much. So grateful to be here with you today, and thank you for having us.
Let's work that algorithm for SSA. Lunchtime, very exciting. So to get to lunch, it's in the same location where pastries were this morning. You're going to go out, take a right to our east lobby. There you'll find box lunches for everybody. We ask that you be back by 12:25, so this is the fastest lunch you've ever had in your life. And at the same time, as you walk out at the registration table, there is a bowl for raffle entries where you can try to get one of the pieces of artwork or a signed poster. So we will see you back here at 12:25. All right, everyone. Our next session today is an intimate fireside chat on the topic of sickle cell and reproductive health. Our session will dive into the unique challenges and opportunities for individuals with sickle cell disease and with the sickle cell trait, particularly as it relates to family planning and reproductive health topics near and dear to my heart. We are honored to have with us two incredible women who bring not only personal experience but also passion and advocacy to this conversation. So first up, we have Wumi Mosaku. She is a BAFTA award-winning actor from Los Angeles who most recently starred in the summer blockbuster Deadpool and Wolverine, and she nailed it. Joining her is Yetunde Felix Ukwu, a warrior, transplant survivor, and fellow actor from Kansas City, Missouri. She is also a superb dialect coach. I highly recommend checking it out. And then moderating this very important conversation is Dr. Lydia Pecker from Johns Hopkins University, who is a leading expert in sickle cell and reproductive health. Please join me in welcoming them.
Good afternoon.
Good afternoon.
I would like to welcome you on behalf of myself and the many friends, colleagues, and warriors who are here in the audience today who have lifted me up and supported me through so many things, and they're going to do the same during this conversation today. And we know that superheroes are people too, because I work with many superheroes at the Sickle Cell Center for Adults, and I know many superheroes who live with sickle cell disease. And for them, there is no time. We are in a real rush to make sure that our adult sickle cell patients get the longest lives possible. So there you were, walking on your own timeline, when it wove together with a thread about sickle cell disease. Will you tell us about it?
Yeah, my name is Wumi Masaku, and I am an actor, and I have sickle cell trait. Sorry, I have sickle cell trait. My husband also has sickle cell trait. We found this out in 2020, like it was confirmed with the genetic counseling. And we just decided to do our research and really look into sickle cell disease, something that we'd heard of, never really seen with our eyes, like the effects in people's lives and the pain crises. And yeah, we were a little naive, and we thought maybe we should take this opportunity to really do our homework. And we learned so much. We learned that even people with sickle cell trait could have crises. And we spoke to people, carers. We spoke to people with sickle cell disease. We spoke to hematologists and doctors, and actually a post that I saw on Cassandra's page, Sickle Cell 101, really confounded our decision to do IVF with genetic testing. And that was the reason that the post said, if you have the trait, should you basically take the gamble, or should you be educated and go forth anyway? And I read the comments from everyone who was a warrior, and I felt really convinced that since I had the knowledge, and our wedding got cancelled, and we got our money back, and we were like, I think this is divine, and we decided to do IVF. And so that is a very brief journey of my reproductive journey. Yeah.
And we're living through like an era of science fiction for sickle cell disease. There's not just pre-implantation genetic testing, but some people are using infertility approaches, in vitro fertilization, to actually test embryos for HLA-matched siblings for children, so children can get transplants from matched sibling donors. And then, of course, we've heard about gene therapy, and we'll continue to hear about gene therapy. But all of that starts with education, right? And I wondered if you could talk a little bit about the experience of identifying with your husband that you were both trait carriers.
It's interesting because it's something that came up really quickly on our first date. And I'm English, he's American. I was in America. I just went on a date. I did not know that he was going to be my husband and the father of my children. And it's something, we just, it came and it went. But we weren't 100% sure that he had trait. He said, I think I do, but I'm not 100% sure. I knew I had it, and so that was, it kind of got forgotten about until we were married and wanted to talk about family planning, and we were like, we should double check. And then, I didn't know there were different types of sickle cell disease and traits, and we both have S trait. And, I just started to, in our Nigerian culture, they say AS, SS, AA, and there's nothing in between. I didn't know there were different severities. I didn't know there was beta thalassemia. I just felt like there's so much I didn't know, and until we knew we both had trait, then people in my community kind of talked to me about what it's like to be a carer or to have the disease. And finally we had a little bit of a little window into sickle cell disease. And so, yeah, we decided once we got that gift of our wedding money back, we were like, we can do this, IVF, and then what we definitely need to do is make sure that we use our voice and our position and our relationships to make sure that people know their status, which I feel like is not something that a lot of people, I don't feel like a lot of people, I mean, not a lot of people, a lot of my friends didn't know their status. And I was like, wow, that's really interesting. You should go find out. And so that was like, the beginning of our like thoughts of advocacy. Like, at least from the beginning, know your status.
Yeah, and I always, when I talk to my patients about this, I always say, you don't know what you're going to decide. You don't know what you're going to do with what you learn. And there's a lot of different ways you can gather information. And one of the things that impressed me about your story was that it was like you had read my textbook of where to go gather information. Could you talk about, you talked a little bit about your friends, and you talked a little bit about Sickle Cell 101. Could you talk, it sounds like you talked to some hematologists. You did a lot of homework to make this decision. Will you tell us a little more about that?
Yeah, I spoke to a few mothers of warriors, and I heard the stories about changing from pediatric care to adult care. I was hearing stories about prejudices that would come into play with adult care, and racism and inequality and financial inequality. I have friends who have told me that they have made very, big life. Every decision they make in their life is sickle cell is part of that decision making. Someone I know said they don't get into relationships because relationships are stressful, and stress brings on crises for them. And I just didn't realize how many decisions were being made because of their sickle cell disease. Living close to family, the jobs, the travel, where they choose to, which climate they choose to live in. It was really, I knew that as a parent, I would have a certain amount of, I could be there for a child, but then as an adult, there's something you wouldn't be able to always do, or you're not always around. And so just hearing how people live and thrive, and the struggle and the pain and the decisions that people were having to make, warriors were having to make because of their disease, and then carers. I felt like I just didn't know. Yeah. And I felt like because I had the knowledge, I shouldn't gamble.
One of the things, and I told you this, but one of the things I learned at an NIH meeting some years ago was to be really thoughtful about how we talk about IVF with pre-implantation genetic testing, and you're really modeling that for us. And the reason, the way that was illustrated to me was that a parent of a warrior said, be careful about how you talk about these technologies, because for parents of children with sickle cell disease, you're describing a world without our children, and that's a world without air. And so we never are talking about a world without air when we talk about this reproductive choice that people have. And that's one of the reasons I'm so glad Tunde's with you today. And it's so special that you're here, because we're very glad that you're in the world with us. And we want to hear a little bit about your story, too.
Hi, everyone. My name is Yetunde Felix Uku. I was born with sickle cell HBSS. It didn't start to manifest until about the age of 5, but between the ages of 5 and 13, fetal hemoglobin did a lot towards not letting me get sick. But as puberty came, that kind of was the onset of the worst parts of sickle cell. So I've been taken care of by every hospital in this area. There is a correction. I'm actually from Lanham, Maryland. So Children's National Medical, Washington Hospital Center, Johns Hopkins, all of these institutions have taken care of me. I was privileged to attend University of Maryland Law School, and that is what took me to Baltimore, and that is what took me to be in proximity at Johns Hopkins. When I was kind of at the rock bottom of my illness, where folks weren't sure if I was going to make it. And the bone marrow transplant in 2009, I was one of the first in that cohort, privileged to scale through all the hurdles of insurance and all the things that came along with that. And was privileged to have a half-matched bone marrow transplant in 2009 at Johns Hopkins under the care of Dr. Charles Hesdorfer and Dr. Robert Brodsky. And like was mentioned, I continued to have crises for several years after the transplant. And one of the things that at the time, because the transplant was using such high levels of chemotherapy, they weren't sure if they would take away my ability to reproduce. So the plan was for egg retrieval, but I continued to get so sick that there wasn't time for egg retrieval, so my entire ovary was removed and cryopreserved in efforts towards preserving my ability to have children. So that's why I'm excited to be part of this conversation, because WUMI represents what will be my future, what the process that I will go through in order to ensure that I bring healthy children into the world. So I'm just excited, overwhelmed to be in this space where these kind of conversations are happening, and looking forward to what happens when we bring policymakers and warriors and medical practitioners all in one space. So excited to be here.
Thanks. One of the things that we talk a lot about with being cured of sickle cell disease is it doesn't cure your eggs or your sperm of having sickle trait, right? Yeah. And so could you talk a little bit about how, even though you are living now without sickle cell disease, how that reality has shaped your life in some meaningful ways?
Yeah, so I am Nigerian also, and after my bone marrow transplant, I relocated to live in Nigeria, where I believe I met the love of my life, my soulmate, so to speak. And I, like WUMI, talk about sickle cell first date. Hi, my name is Yetune, I have sickle cell. Just let's get that out of the way because it's such a big factor. And I met a gentleman who just knew that he did not have sickle cell trait. And we proceeded to get close to getting married, and just knew that we were going to spend the rest of our lives together. And it was only because he had to take a blood test for work that he found out that he had sickle cell trait. And this is in 2012, I believe, you know, fresh off the transplant. And I was in a similar position to WUMI, and it was the question of, do we break up or do we move forward and take the gamble? And he, as a person who had trait and no symptoms, no kind of awareness of sickle cell, wanted to take the gamble. But as a person who had just kind of was just climbing out of the throes of a life that had been so drastically affected by sickle cell, I wasn't willing to take that chance, because the treatments that are available now, I didn't know that they were if they were available back then. And so I made the hard decision to end that relationship so as to not take the gamble. And so, yeah, it has affected my life in that I do have to have those conversations very early on, and I do have to be careful who I select as a partner, because I have had the transplant and I grafted completely to my sister. My blood type changed, but genetically, my eggs, my ovary that is frozen, will produce children that have sickle cell trait, at least from me. So I do have to be mindful of who I choose as a partner. So, yeah.
Both of you have talked about the role of stigma in sort of your knowledge and your lack of knowledge. Will you talk a little bit about that from your experience as Nigerians, Nigerian Americans, British Nigerians?
Well, I didn't really know what the stigma was until, except for the fact that no one really talked about it. I think once we found out we both had S trait and I told my mom, then the community kind of came to me, and I realized that people who I was very close with had sickle cell disease. People who, I've literally grown up my whole life with, and I just never knew. I didn't think it was a stigma until talking to Yetunde about it, and I was like, I just thought Nigerians were quite secretive, and I thought it was just that. But then listening to Yetunde about her experience living in Nigeria, I was like, oh, even the fact that I have S trait in Nigeria is like.
I was explaining to her that even having trait, because there is now more awareness about know your status, once you have trait, it's like you are unmarriable, you are undateable. For those who do have sickle cell, it's like the stigma is attached to they'll never be able to hold a job, they'll never be able to go to school, they'll never be able to have a successful relationship, so why even bother? Once you perhaps have a stroke or, AVN affects your hips, which is quite common, and you move through the world differently, the stigma on physically how you appear is something that is very strong in Nigeria. So there is deep secrecy around if you have it and you can move through the world without any outward signs about keeping it private. Things are changing now. But I do remember when I was living in Nigeria and I did have that, hi, my name is Yetunde, I have sickle cell, people would be like, shh, don't say that loudly. And so that's kind of where my advocacy began about no, I'm going to be loud about this, I'm going to be proud about this, and take away the shame associated with having a genetic disease that's not contagious. Right. We talked about that. Right. It's not contagious. And just, I think it's not based in any malintent. It's just lack of awareness. It's just lack of awareness.
And there's also, sometimes there's mythology kind of in there too. I read this book, Stay With Me, and I realized the story of Stay With Me without, I guess it's a little bit of a spoiler. But it is about a woman who loses multiple children, and there's, what's the name that
Ogbanje.
Ogbanje. And they say that the children are Ogbanje. And actually, the children have sickle cell disease. And I realized when I read that book that I have a story like that in my family history of a woman who's a great-great-great-great-great-grandma who lost a lot of children. And I'm like, oh, it was sickle cell disease, but it's presented to me like a story, a mythology, otherworldly. And that was just something that was, I heard that story and I took it as the mythology until I read that book, Stay With Me. And then I was like, wow, I never knew.
Story you were hearing.
Yeah.
I wanted, I love that story because, people in the United States sometimes talk about sickle cell disease as if it's a homogenous disease that affects Black people, but actually it affects a hugely diverse population of people who are from all around the world, who speak every different language and who have every different skin color, right? We have large populations of people in the Middle East and other places, and so I really appreciate that story because it's, in this country we now have universal childhood survival, but there are still places in the world where we know that that's not a reality, and that these stories have particular power there. I wanted to pivot because here in the US there's been a growing interest in fertility preservation for sickle cell disease in the setting of gene therapies and transplant. And both of you, though for slightly different indications, have gone through the process of assisted reproductive technologies. And I wondered if you could talk a little bit about what it's like to have your ovary in a freezer, what it's like to go through the process of IVF, and just tell people a little bit about that, because a lot of our warriors are learning, and actually our doctors also are learning about that together as a community.
Oh, well, yeah. So for me, reproductive preservation was a frontier that almost prevented me from being able to move forward. Like I said, I was so sick that there was no time for egg retrieval. The egg retrieval is not a quick process. It happens with every cycle. And because I was getting too ill to participate in the research, it was like the decision was made for the ovary. And it was a barrier because that was something that prevented insurance from wanting to move forward. Insurance was not wanting to cooperate kind of for any of it because it was so new. And that's where doctors came in and were writing personal notes. And my ovary retrieval surgery, the doctor who performed the surgery actually did it for free and waived all of his fees so that I could have it. And I just, I was very meticulous about keeping a blog and just documenting it, because I knew even at the time that it was like science fiction. It was like, wow, this is the stuff that you see on movies and television, and I'm getting to experience it. Women now, with or without sickle cell, are more familiar with egg retrieval now than they were back in 2008 and 2009. But yeah, it's cryopreserved, and when I am ready to use it, there's a process by which the eggs will be taken out and then implanted in my, I don't know if that's still true, but at the time, the eggs need to be taken out and kind of defrosted in my arm.
The tissue will be reimplanted, right? Replanted.
And so I am curious and excited to see what that means when I do have a partner that I'm ready to create children with. But every year I get an email saying, just letting you know, your cells are still safe with us. And I'm just, I can't believe it sometimes. Yeah.
IVF is the least sexiest way to create life. It's, I found it, there's this illusion that you have some sort of control, but you really still have to surrender and let go, because as much as you think, oh, we're going to do this, and 25% of our embryos will be sickle cell free, 50% will be sickle cell trait, and 25% will have sickle cell disease. It's just not that at all. And there's also the process of every single day you get told something, like you lose the numbers and of possibility. And I wasn't really prepared for that. We were doing this in the pandemic, and so no one kind of wonders of, like, every time we call you, it's bad news, but it is bad news, like, and you kind of lose a little bit of, like, hope, and you get anxious, but then you get, you go through the whole thing, and then you get the positive pregnancy test, like 10 weeks post implantation or something, and it's, and it's still nerve-wracking because you still got to get through the first trimester, the second and third, and then through the delivery, and then maternal
antenatal, postpartum,
maternal postpartum depression,
or the fear
just being a mother,
of having a baby,
the lifetime of worry that you have once your child is alive on Earth.
But also just being a black woman in the medical world, there's that fear as well. It's like, am I safe? Is everything going to be okay? And I felt like I was holding my breath until I was holding my baby, I could finally breathe out. Yeah. But even then, like, then she's here, and then you have to protect her forever. So yeah, IVF is just, I thought I had some control, and I realized very quickly that you don't, and it is still up to the Creator. It is still up to God, and that is it. Like, you are at the whim of life. That's it. It's of life. And yeah, no, actually, I was about to tangent that. No. Well, no, it was about I wanted to touch base about the insurance as well about it, because I do think this is really important because of how expensive and sickle cell care is for the warriors and for the caregivers. I felt like it was really unfair that the IVF wasn't covered. Like I said, I was very fortunate that, you know, the wedding we had been paying bits to for the last year, and we had wedding insurance, thank God. And they only told us to get wedding insurance because I'm married to an American and we were getting married in England. And they were like, they're American. If someone was to trip up, they might sue you. You should get wedding insurance. Because that's what Americans do, sue. And so we were like the only people I know who ever had wedding insurance. And we thankfully, I was just so, I felt, it was such a...
Mention that your wedding was canceled because of the pandemic.
Oh, it was canceled because of the pandemic. I don't know if it was May 9th, 2020, and it didn't happen. But we still got married, just in our dining room. Yeah, so I feel like that's really important too, because I feel like the money that we just spent out of our own pocket has actually saved the insurers so much money. I feel like I feel so privileged, so lucky. I mean, 2020, like, it feels really unfair that it's only available to people who can afford that and have the cash like now, but people are spending far more than that on the care and giving care and getting care in the long run. And I do feel like that's something that really should be addressed, needs to be addressed, because it's not fair.
I just want to add that also during my transplant, there were many times where the insurance just flat out denied it. And I specifically remember that one of my social workers partnered with the administration of the hospital to calculate how much more a lifetime of care of insuring me would cost them if they said no to the transplant then. So it's like the transplant now or her life time in private rooms with all the things necessary that come along with being a person who has sickle cell illness, infection requiring her to be in the ICU. There's this number that you keep saying no to, and there's this number that will inevitably result if you don't say yes now. And that's when the change happened, and they said, okay, go ahead and give her the transplant.
Yeah. You've both been through so much. I wondered if you could talk to us a little bit. One of the things we do in my clinic for young adults is we talk a lot with young adults about talking to partners about these issues. And so, you know, you mentioned it came up on the first date, but then, actually there's two parts of this. I mean, this is a dealer's choice question. You said it came up on the first date, and you've talked about making really difficult relationship decisions based on this, this issue. And So part of it is about, my question is about how you talk to your partners and potential partners about this and how you practiced doing that, rehearsed maybe. And my other question is really about another stigmatized dimension of sickle cell disease, which is the need for mental health care. And we see this also in infertility care. You sort of mentioned there's just this gaping hole of uncertainty when you go through these processes. I wondered if the two of you could talk a little bit about your mental health and well-being and talking to your partners and navigating the stress of those kinds of dynamics.
I had a therapist during the process of 2022 up until last year, I think, and I just think therapy is just necessary in all things. But I had someone specifically for this journey of matrescence. And then in regards to speaking with my partner, like I said, it came up on the first date and it didn't come up for another 4 years, which, you know.
Well, we talked about Romeo and Juliet, right? That's not how love works.
Right. I feel like I think I'm glad it didn't come up for 4 years, because if we really sat on it, we may have made a similar decision of parting ways. But thankfully, by the time we were ready to start a family, and we were gifted the knowledge of the sickle cell S trait, and then a year later, we were given our money back, and therefore we went down this route, and we just had that basically a year of like research together before we got our money back. And then we made a decision, like I said, it was really that, all the conversations we had. I joined a mums group on Facebook, Sickle Cell Mums group, and just reading about the gene therapies and everything, and then that post on Sickle Cell 101 and listening to the warriors' response, every single warrior. I just was like, okay. We were like, okay, we're making this decision. But if we hadn't had that year of research and conversation, and we made a decision in 2017, we may have made a very different decision. And thankfully, we had the time and then the resources.
Yes.
For the how to talk about it with partners, it's such a big part of my life. I'm Nigerian. There was a small part of me that, you know, wasn't sure if I could marry a Nigerian, because the likelihood of a fellow Nigerian having trait. So then it affects like who you go for versus who you're attracted to, because it's just a part of my life that the transplant stopped the pain, but it didn't stop the impact of the disease. And then that transitions into the mental health. I currently have 2 therapists and a psychiatrist, because the depression doesn't stop because of the transplant. The anxiety doesn't stop because of the transplant. The suicidality didn't stop because of the transplant. A lot of those things are still being unpacked 15 years later. My friends and I have a joke that I'm actually a 15-year-old, because in many ways, my life pre-transplant was so disrupted that it only feels like I really got started on adulthood 15 years ago, right? I didn't learn how to pay taxes until maybe 2 or 3 years ago, because I had never had a job, because I couldn't hold a job because of sickle cell. So I feel like sometimes failure to launch is a thing that, you know, delayed onset adulthood is a thing that I'm working through. So anyway, I just say all these things to say I do feel incredibly privileged that I was able to have the transplant. And yes, that made the pain stop. But the impact of this disease will be with me for the rest of my life. And so I am a huge proponent for mental health. And I almost wish I had more mental health while I had sickle cell. You know, it wasn't until social workers started providing kind of comprehensive care that doctors started thinking about that. It's like, maybe this girl who is on these high levels of narcotics could use someone to talk to. That wasn't a thought all the time back then. And so psychiatric nurses being part of my care wasn't until the latter parts. And so now that I'm an adult, now that I'm a self-advocate, I fight so hard for my mental health on a daily basis. And I'm glad that you brought this question up, and I'm glad that it's something that we're realizing needs to be part of the conversation, that medication and science and all of those things are very important, but what's going on up here is equally as important.
We just have a few minutes left. I wanted to just acknowledge how your stories make our story bigger in sickle cell. You know, one of the stories that needs to get bigger for our community is that without in vitro fertilization, fertility preservation is only half the battle, right? And without late effects care, without the long-term vision that people who've been exposed to cures and transformative therapies for sickle cell disease continue to live with the consequences of having had sickle cell disease, of being exposed to these preparative regimens, that we need to take a much more expansive view of what it means to solve problems for sickle cell disease. So thank you for lending your stories to that story, because it's the one that we're trying, a lot of people in this room are trying to tell in a way to make things better for people. I wondered if you had any last thoughts you wanted to share about access or changing things.
I think me sitting on this stage with you and talking to you is a beautiful step. You know, once I found out that this was happening, I then activated my network of warriors, like, did you know that this was happening? And so I think there's a lot of onus put on warriors kind of to be their own fierce advocates and speak up for what you need. But I love conferences like this that kind of say, hey, let us take the lead and let us lead the way and take some of the burden off and present some information and bring the teams together so that it's not me going to find all the things that I need and you know, going down rabbit holes to figure this out, but a venue like this, bringing all of these organizations, bringing all of these departments to one place. These panels have been informative, but for me, the highlight was lunch, where I could say, hey, let me get your number. Hey, let me connect with you on social media. Hey, so these spaces where we get brought together to rub minds, to share information, need to happen more frequently and more often, and it is the exchange of information that propels us forward.
I feel like I really want to say thank you for everyone who's ever shared and spoken up about their life with sickle cell disease, their life as a carer. I am indebted to you. My family is indebted to you, because I felt like I was able to make an informed decision with a gift that fell back into my lap. And I'm just so grateful. But yeah, I feel like the Warriors have such a huge fight on their hands that it's for everyone to really speak on their behalf too, with them, amplify their voices. But I don't want the work to be on your shoulders because you have enough to shoulder. So I feel like, thank you, because I feel like that's what's inspired me to speak up. Like, this is the first time I've spoken about IVF and my journey, in public. And so I'm glad to be here, and I vow to do as much as I can, and thank you for letting me in so that I knew more.
Thank you.
I have small gifts of thanks from the Johns Hopkins Sickle Cell Center for Adults, who send their love to you. Everybody's so proud of you. And their gratitude to you.
Thank you so much.
Thanks, everyone.
A warm, heartfelt thank you to Omi Yatende and Dr. Lydia. That was remarkable. And Yatende gave us a charge here, which is to focus on quality of life, right? Not just advancing and expanding the lifespan, but quality of life. And what a perfect segue into the second half of our day, which is a greater focus now on quality of life, on research, and on partnerships, all to that effort. And so our next panel is on state and private sector innovations in sickle cell disease. It will showcase success stories across a diverse range of topics and regions. Moderating this session with us is Dr. Patricia Kavanaugh from the Boston University School of Medicine and Emergency Department Sickle Cell Care Coalition. She will speak with Mrs. Mary Brown, President and CEO of the Sickle Cell Disease Foundation in Ontario, California. Ms. Annie Ross-Womack is the Executive Director of the Ohio chapter of SCDAA, or the Ohio Sickle Cell and Health Association in Columbus, Ohio. Dr. Brian Dixon, Director of the Public Health Informatics from the Regan Streif Institute in Indianapolis, Indiana. And last but not least, Dr. Omolola Taiwo, Executive Director of the Performance Management Unit at the New Jersey Department of Health in Trenton, New Jersey. Let's give them a hand.
Good afternoon, everyone. All right, good afternoon. All right, you're giving us a little bit of momentum here because that was a very hard act to follow. That was so powerful and beautiful, and I'm so glad to be listening to it even in backstage. So my name is Dr. Patricia Kavanaugh. I worked in the Pediatric Emergency Department at Boston Medical Center for 15 years. But I'm here today to talk to you about the Emergency Department Sickle Cell Care Coalition. This organization was founded by myself and a warrior back in 2015, and it serves as a national forum, a clearinghouse, if you will, of ideas and dissemination of important strategies to improve sickle cell care nationally, including for adults with sickle cell disease. We have administrative support by the American College of Emergency Physicians, and we've had it since day one. We're a unique organization in that when we came together, it was very purposeful. It represents the emergency department community, including doctors as well as nurses. It represents hematology, both adult and pediatric providers. It represents federal agencies, including HRSA, CDC, and NHLBI. It represents the community organizations nationally, and it also includes the Joint Commission. Last but not least, most importantly, really, since its inception, we've always had 2 individuals living with sickle cell disease as part of our coalition. So I'm here today to share with you some of the important initiatives we've done. I think the most important thing that we could do is to really educate our ER clinicians about sickle cell disease and the proper care that is required. All too often, care is not optimal if it's delivered at all. And so we need to change that, and that's why we've all come together. So I just wanted to highlight a couple of opportunities that we've had since we were founded. The first was actually sponsored by the Department of Health and Human Services, the Office of Minority Health, was actually a supplement in the flagship journal for emergency medicine providers, the Annals of Emergency Medicine. So this was a supplement in September 2020, and all 11 research articles included in that was only about sickle cell disease, and it was targeted towards ER clinicians, including best practices, how to take care of patients with sickle cell disease. But that's not enough. The other thing I wanted to highlight is that we need to get to our clinicians. And so we've given talks across the country at regional meetings, at national meetings of ER clinicians. And in fact, a week from today, I will be joined on stage by the president of ACEP, Dr. Aisha Terry, who has sickle cell trait herself, as well as other leaders of EDSC3, to give an educational session. We were an invited panel to come and speak about it. And so we were selected out of 100 of applicants, but they are really focused on doing better for sickle cell disease, and they know education is a big problem among their members. The last thing I really wanted to highlight is that in 2020, a group of us came together and created a freely available tool that you can all Google right now on your phones. If you put in ACEP, A-C-E-P, and if you put in point of care tool, you will come to a list of freely available point of care tools that ACEP members, ED physicians, use all the time. One of them is on sickle cell disease, and it has 6 domains, including communication, believe the patient, patient report of pain is the gold standard, triage, must be at a high level, ESI 2, because they need to be seen, they need to get into care, into the back as quickly as possible. Management, look for an individualized pain plan. If one does not exist, here are 2 tables, one for children, one for adults. Weight-based treatments, not the 2 milligrams of morphine that I've heard stories about adults who weigh more than I do. We don't even give that to babies. We give a little bit more. And so that tool, freely available, I wanted everyone in this room to know, exists and is being used by our ED friends. Since it was launched in October of 2021, in 2022, 2023, it was the most heavily used tool on that site. And even right now in 2024, every month it is the most frequently used tool. So the ED community is coming around. It's been so slow. I feel like sometimes I'm stuck in a vat of mud, but it is coming together. One last piece that CMS did not mention today, but I'm so wildly excited about, is that there is a quality measure that is being developed around emergency department care. And I'm happy that EDSC3 has such sway within ACEP, because ACEP was at the table working with hematology and other folks to come up with this measure. It's still draft, but the measure will be time from ED arrival to time to first pain medication. There will be a subset, thanks to everyone who may have commented on it, and perhaps I commented a few times, that there will be a specific section that is going to also measure time to first opioid, because that's what the guidelines recommend. So I'm here to say that work is being done. We are working together, and so there is hope in the ED that we will do better. We must.
My name is Mary Brown, and I'm the president and CEO at the Sickle Cell Disease Foundation. And today I want to talk to you about a labor of love. In California, under the leadership of Dr. Diane Nugent and with my friend Jennifer Fields, we created 12 adult sickle cell clinics. And we did that with champions Mike Gibson, who is Assembly member in Los Angeles, as well as Tony Gonzalez. They taught us how to advocate for and push our story toward resolution in California, because people in California were dying way too early. And frankly, I was a little tired of going to funerals. I was also tired of sitting in a room like this and others with a lot of well-intentioned people who talked about resolutions but never any action. We came to this place where we had to get something done. And today I'm happy to report that, again, we have 12 clinics that are seeing patients Over 1,000 patients now in California are receiving this care. CMS today also described and discussed 4 methods that they have identified, and NCSCC checks all 4. 1, 2, 3, 4. I'm asking you all today to go forward, to be actionable. Stop talking and let's start doing. People with this disease don't want anything more than anyone else in this room. Think about that. They don't want anything more than I would want for myself. They want to live high quality lives. They want to be able to do what they want to do. There's a lot of power in this room, folks. All we have to do is put our heads together. And let's not leave this room today without a reason to continue to advocate for people with sickle cell disease. That's my life's mission. I didn't choose it, but I think it was pushed upon me by God Almighty, and I thank Him for it. We have family, we have friends. We need to do something about it. And in California we have, but we're not finished yet. We have so much work to do. So when you start something, I'm going to suggest you try to finish it. Because if you can't finish it, why start it? Thank you.
Greetings. First of all, thank you for the invitation to be here on this illustrious panel. I am Annie J. Ross Womack. I am at the Sickle Cell Disease Association of America, Ohio Sickle Cell and Health Association, Incorporated. I would like to thank our board chair who's in the audience, our members, Madam Cleary, and you've heard from our illustrious Dr. Donnell Ivey, and our president and CEO, Ms. Regina Hartfield, and then all of my fellow community-based organizations that are out here in the audience, and then, of course, our warriors. I am here to talk to you about an innovative project that we started years ago at the Sickle Cell Disease Association of America, partnering with MedicAlert. So the great thing is that in the first segment, you've heard Mr. Jimmy speak about him finally enrolling, and it gives our warriors an opportunity to understand that they need a medical plain pan and also have their information stored. So this MedicAlert project kind of monitors that in the ER, because we all have heard the stories of our warriors spending countless of hours sitting in the ER, some 5 hours, some 8 hours, some 12 hours, some over 24 hours, sitting in pain in an emergency room waiting to be seen. So this pilot project was first offered in minimal states, and then it moved into 15 states, and now it's available to any warrior in the United States that would allow MedicAlert to, yeah, please clap. Please clap. Any warrior to be able to report out to MedicAlert about not only their experiences in the ER, but then also to see if them having that information available. You heard from Tristan when he talked about having those 5 things. But if you're incapacitated and you're there writhing in pain, I'm not thinking about the 5 things. I'm thinking about get me in the back, hook me up to whatever I need to be hooked up to. This allows those physicians to be able, and that ER staff to be able to pull their medical record out of a system. So it's a pilot project. We're going to see if it works, but I need, when you leave here, as Mary Brown said, when you leave this place, make sure that you equipped our warriors with the tools necessary. Put your speaking words to action, put that to feet, and let's walk out what we're saying in this place. And that goes for our CBO leaders, our warriors, and everyone in this room who has access to anyone in the sickle cell disease family. Thank you.
Good afternoon. I'm Brian Dixon, and I am with the Regenstrief Institute, and I feel a little out of place because I'm a data geek up here with all these wonderful people on the panel. But I represent the Regenstrief Institute. We're a nonprofit organization that conducts and translates impactful research and development solutions for a healthier and more equitable world. My work is at the intersection of computer science and epidemiology, and I build solutions for public health that improve the capture, management, and analysis of data. We are one of the partners that's involved with the Sickle Cell Disease Collection Program, the SCDC, that Captain Burton talked about, in Indiana. So we became part of the SCDC in 2020, and my organization in particular works on connecting together and linking data. So we link together the Medicaid program data with the clinical data in our statewide health information exchange. So our focus is really on building a statewide infrastructure for collecting not just the diagnostic codes, but medications and lab values and other clinical data elements for people with sickle cell disease that are living in Indiana. And that's really important, because I think as what struck me when Captain Burton was talking and the other sessions today is that our real mission and focus is to make people visible, make people with sickle cell disease visible, and the way that we do that is by making data accessible to public health and policymakers. So our enhanced surveillance system that we've been working on over the last couple of years has been able to identify 200 additional people living in Indiana with sickle cell disease, which has made them visible. And so I kind of liken it to the census. You have to be counted and measured if you want to be able to make progress. And so that's allowing our state to understand that there's more people than ever who are living with this disease, and that our numbers are growing year over year, which is causing policymakers and public health officials in the state to take notice and to begin to prioritize care for sickle cell, ensuring access and the other things that we've been talking about today. So in addition to just linking the data, we were asked to create a publicly available dashboard to represent the data in the SCDC program. And I know we don't have slides or anything to show you the dashboard, so I would encourage you to go online and see it. It's at regenstrief.org, and that's REGENSTRIEF. I know it's a long German name, but that's the name of our institute. And we employed user-centered design techniques to create the site that enables community organizations, the CBOs that we've talked about, families and others to see the SCD population in Indiana. The site provides key metrics such as the prevalence of sickle cell disease in the state and in each county. For example, we see that SCD patients primarily live in urban areas, but we also see that there's a significant number of patients in rural counties that live far from specialists. We also provide information on common comorbidities like asthma. This allows us to monitor, for example, asthma care in both urban and rural communities for SCD patients. It also allows us to look at mortality information and incidence rates over time. The population has steadily grown over time, and we now are able to see all of those adults who are living with SCD in the state. Our dashboard work and surveillance efforts have established a robust baseline that we can now use to monitor trends in the data and share that with our partners to support patient education programs with our CBO partners, research, policy development with the State Health Department, and health systems planning with our provider partners. We're a proud partner of the SCDC community in Indiana, and we hope that efforts like ours become broadly available so that the entire SCD community in the nation can access and use information to support care and improve outcomes for SCD warriors. We're working now with other states in the CDC program to share our knowledge and support other SCDC programs in building tools like the ones that we have in Indiana. Thank you.
Thank you. Yep, now you can hear me. All right. Hi, so my name is Dr. Taiwo. I'm Alola Taiwo from the New Jersey Department of Health. I'm here to talk about a pilot program that Governor Murphy signed into legislation earlier this year in January. This pilot program was really a very innovative way of making sure that patients, sickle cell patients within New Jersey, had access to care within their communities. So really the goal is to help ensure that there are federally qualified health centers piloting in 6 municipalities currently, but making sure that our federally qualified health centers have the capacity to serve their patients that are walking through their doors that have sickle cell, making sure that they can do coordination of care with their hematologists and other specialists, making sure that there's a network of sickle cell providers and folks who understand sickle cell within the community. And so, we are at the beginning of this process, and I'm incredibly honored to have been invited here on behalf of Jersey, and then also be sitting on this panel, because these are the partners that we are excited to work with and to bring to New Jersey, really developing that network and trying to get a better understanding of who's in the space. There was a dearth of practitioners, hematologists, sickle cell specialists in New Jersey, and so piecemealing this through all of the lovely hematologists that we've worked with at Newark Beth Israel or Cooper and other health systems within Jersey that have said, hey, there's not a lot of me, so I'm going to help create this infrastructure. We have been really working fairly hard to make sure that our centers, our federally qualified health centers, have the capacity, have access to education and to resources and to these tools and to the data. So you're in a good place, so that they are equipped to, service this population. Our federally qualified health centers are in a really unique position because majority of them are primary medical home. And so the idea that a patient can walk in the door and have access to a PCP, as Jimmy had mentioned, that a lot of our PCPs are not very aware of sickle cell disease, have access to a dentist, have access to an OBGYN, licensed clinical social worker. All of those folks that are actually housed in the same location, that would be amazing to make sure that all of those folks have at least a baseline or a good understanding of what it means to be living with sickle cell, what it means to treat a person with sickle cell. And so that's really kind of our goal at this moment. So between this bill and the CDC grant that our state also has, starting to understand the data, where are patients, who has a primary care home, who doesn't have a primary care home, are they accessing services within Jersey or within our neighboring areas? We're right in between Philadelphia and New York, so people are often going to, outside the border to get care. So our network is obviously going to expand across those borders because it's really wherever patients are going, that is where we need to make sure that we're connecting to. Making sure our systems are talking to each other. That interoperability is a major challenge, and so how to ensure that the folks that are working every day and our providers within the FQHCs, that's a lot of work for them. So if there's anything from the state perspective that we can do to help facilitate that process, that's really what those goals are as well. But yeah, it's we're at the infancy of this process, right? This is a 3-year pilot. We are, what is this, month 9 into the process. We're just now starting to get the FQHCs, they're officially grantees through the department, and so getting them up and running. But there's, lots of work in progress that's happening, but making sure that we continue the communication with the folks on this panel, with the folks that have been in this room, to help provide that safety net for our state as well. We're a small but mighty state, lots of people, lots of challenges, but I genuinely am excited to be in the room because now we have these resources and we have these partnerships. So thank you.
All right. Good. So as the moderator, I had a couple of questions for our panelists. Hopefully you've enjoyed their presentations as much as I have, and I've learned quite a bit. But the one question I had for each of you is, how do you ensure, with all of the programs that you do, that the warrior voice is front and center?
How do I ensure that the warrior voice is front and center? It's pretty simple for us. They're part of our organization. And everything we do, every program or decision we make that totally affects them, we have to ask them, is this something that you want? So when we created the clinics under a requirement of HRSA, we had to have what's called a state action plan. And in that state action plan, there were warriors, there were clinicians, there were researchers, all talking about what was required or what was needed in California to take care of them. We took that state action plan and put that into motion when we got the $15 million from the state. So the warrior voice is there 24/7. We don't do anything without consulting with them in small groups, one-on-one, or in parent groups. They're always a part.
Great. In our organization, 50% of my employees have sickle cell disease. 25% of my employees are parents of warriors. My advocacy group is made up of all sickle cell warriors and families. Our office is in the community where our sickle cell warriors live, and we have monthly support group meetings, all warrior-led. They pick the topics, and we have those in our major cities, Akron, Cincinnati, Cleveland, Columbus, Dayton, and Toledo. So, and then all subsidiary counties. So our organization was founded by warriors, partially ran by warriors, and we are there for the warriors.
Is this one on yet? Okay. Yeah. Okay. I'll straight you for a minute. As I mentioned, we're part of the SCDC program in Indiana, and those programs are required to have CBO partners and families and warriors involved. And so when we went about creating our both the data system as well as the dashboard, we explicitly involved our patient advocates and our CBO partners in that development process. So I alluded to a user-centered design, which means that we came up with just drawings on paper at first, and we asked the group multiple times, like, what data is important to you? What are the things that you want us to make sure are measured and put into the data collection system and are represented on this dashboard? And we iterated on that multiple times. So first it was paper, then it was sort of a working prototype, and then it was sort of a beta version, and they continuously came back and gave us feedback. And so we refined it so that we got the images that they wanted, like graphs that were meaningful to them, that they could use, that they could put in grant applications if they're a CBO, to bring in resources to take care of the community. They said these are the data and this is the information that we need, and we're continuing to engage them as we look at updating the dashboard each year. Our SCDC program continues to expand what data is being collected in the system with their input, and then we reflect that back on the dashboard. So that's a really important, I think, aspect of both the program, but just what we've all been talking about here today, which is that ensuring that warrior voices and families are involved in all of this process, whether it's design of access to care intervention programs or policy at the state level or data systems where we're collecting information about SCD to improve SCD care.
So for New Jersey, warrior voices have been a part of really, the development of the legislation, our development of the RFA. As Brian had mentioned with the CDC grant, they are a part of the multidisciplinary group that is required for the grant. And then beyond that, and as we kind of enter into this implementation side, making sure that we're working with our, New Jersey chapter of the Sickle Cell Association, making sure that those voices are part of that iterative process. Because this is a pilot, everything's going to be iterative. And so making sure that there are measures put into the patient satisfaction surveys of our FQHCs so that they can get those, consistent feedback as they're implementing, as they're going through, from phase 1 to phase 2 into our year 3. And so our goal is to make sure that those voices are a part of every iteration, and we're adjusting as we go along. And so we're hoping that they also hold us accountable. And that's also a really key thing. This is a pilot, and we would love to see, as we said, there's right now 6 municipalities that were embedded into this. We have 23 FQHCs and 2 FQHC lookalikes. And so to see this scale up even beyond that would be amazing. And so we're really trying to make sure that the measures that are put in place now give us the data that we need to move forward beyond the next 3 years.
Great. All right, so I think I have time for one more question, and this one's the hard one. Many sickle cell disease advancements hinge on increasing awareness about sickle cell disease, about what warriors need, and really what kind of care they need provided to them. So can you discuss how you've engaged with and educated healthcare providers to make all of your programs successful?
I think it's part of the DNA of our organization. And I say that because the foundation was founded by 4 African American physicians. So we've had a relationship with providers throughout our tenure as an organization for over 67 years. I think what the change has been, though, has been the voice of the community, and bringing that voice into board meetings, bringing the voice of the community into all the things that we've ever done as an organization. And that's what I believe, honestly, has really kind of set us a little bit to the side of working with other groups, because physicians have always been a part of who we are. And it's been important that we've had Dr. Nugent, Dr. Claster, several of the other physicians working with us to educate other physicians. And so that's just been a part of our organization's internal function, and it's worked out very well. And it also helps us to continue to have trust in the system, because they're there helping other physicians to understand what we need in the sickle cell disease community. And it is the reason, in my humble opinion, why we have been so successful in implementing these 12 clinics, is because we've had physicians that have been with us all along the way to help other physicians to understand the story of the person with sickle cell disease.
In Ohio, we're fortunate to have an advanced network. We started in 1960 out of a FQHC. Our director, our first ever director, and I tell this story wherever I go, on Sunday she will be 92 years old. She and 3 other women, 4 doctors, started this organization. They went door to door with Head Start programs, and they were doing testing. They were doing all those things in an FQHC. So we understand the history of working with not only our physicians, but our community, our nurses, our educators, our teachers. So now, fast forward, I see one of our state project directors in the back, Dr. Lisa, I don't know her last 2 years, got married, Dr. Lisa Shook. But in all of those cities I mentioned, we have robust sickle cell clinics ran by great, I will say women, because they're all women. I'm just saying that because they're all women. Great women who have a grasp on this disease and they understand. And so they go out, we all go out and educate, but they're hospital-based. We have 2 that are not hospital-based, but in those hospitals, they lead in educating. They run clinics and workshops, and their medical directors are the best in the state. I would say the best in the world, but they're the best in the state. I don't want anybody to get upset with me. But we have our MERAC committee, and we have 2 Ohio doctors on MERAC, so I can boast on that. but they make sure that we all are educated, from the lay professionals to the professionals, our community health workers. They run genetic counseling clinics. They do it all, because we have to understand that we have to make sure that everyone in our state is educated, not just our physicians, our nurses, the hospital staff, clinical staff. We never want to hear somebody go into another clinic and they say, sickle what? They actually wrote a book. Sickle what? We don't want to hear that again. We want to make sure that all of our physicians, hospital staff, nurses, clinic staff are educated on sickle cell disease, and I think we do a great job.
Oh, Annie, you can help us then. Because that's where we're trying to go. Yeah, so one of the components of that bill is also to ensure that, or legislation is also to ensure that the medical workforce has an increased understanding of sickle cell. And so one of the things that we've tapped into, New Jersey's medical or physician license requires that all providers take an opioid CME course. And so we've been working with the Opioid Resource Network and other providers to help create a sickle cell-based course, ensuring that all providers have access to this and are able to understand, you know, coming from an emergency room or, you know, really any one-of-the-mill physician, that not conflating the opioid crisis with sickle cell, understanding if a patient comes in the door, this is what they need and this is, you know, how to treat them, making sure that they know the best practices and the guidelines, and that they know where to go in order to access those resources. And so that was kind of the bare bone way in which we can ensure that everybody was getting some baseline, but working towards ensuring that there's, you know, face-to-face training, that there's peer-to-peer training, that all of those components are also there, is something that we would love to get to in the next couple of years. So, hi Annie, we won't be friends.
I think there's a lot we could learn from Amy too, and since she's right next door, I'll probably hit her. Annie. A lot. I'll call you up later because we have a lot to learn from you as well. I think two things that we've done so far. So as a researcher, I'm typically just sort of in a corner in the dark, you know, doing my own thing and producing data. But we also train medical students at our institution, and so I've had a lot of students come in, and we train them on informatics using the SCDC as an example, and so we've gotten more, you know, to expand the workforce. We're focusing on ensuring medical students also understand the disease and the importance of providing equitable care for the disease. The other thing is that we also work with undergraduate students, and I had students come in and work on infographics, so trying to visualize the data in a way that a lay audience can understand it better, and we've taken those infographics to our state's SCD Summit at the State House. And so some advocacy folks that are part of our SCDC network through their organizations have used those infographics to share with policymakers in order to also make it more understandable to them. Again, making the people behind, so they tell the stories and then the data make it more visible to our policymakers. So those are two of the things that we're doing, but clearly we can be doing more. So.
All right. I'm looking around to David. Are we done, or can I sneak in one more question? 8 minutes. Oh, we still have time. All right, perfect. Okay, so, all right, this is a fun question. I think what's so important is, you know, I think we make it sound maybe easy or easier, but I think the important thing to share with people who may be earlier in their journey, and I'm looking at Annie and Mary and myself, to really say, how did you get started? How did something that seems like it's moving along, it's so established, it's so mature, it's able to do so much, how did it actually start? I'll start because I guess I'm the newest of the organizations among the three of us. So for me, it started because I had done some work at Boston Medical Center to improve care for children with sickle cell disease, and I showed that if you decrease the time to that first opioid that was given in the ER, we were sending a lot more children home, and they were not coming back with a pain crisis. They were doing really well. And then I started really working with our adult providers to really say, we need individual, it was a different landscape there. BMC is the 11th busiest and highest volume emergency department in the country. We're level 1, very busy. How do we get sickle cell disease on the roadmap? But then when you start saying, if everyone knows what's going on, if we use individualized care plans, we can actually make disposition decisions sooner. And that really resonated with a busy ER. Do they need to be admitted? Can they go home? Let's follow the protocol and get them treated, and then we can make these plans for them. But in 2014, I had done all this work, published it. I was actually sadder than ever because I didn't think anyone was going to read it, use it, or really much care. And that's when I started, it was just a patient reached out to me, was talking about the ER, had seen one of the early, I think she had seen a talk I had given and was saying, can we do something? And so there was a meeting at University of Maryland with a few people who had similar interests, and they all came in on a Saturday, no funding, and we all just sat around in a room together and said, could we do this? And ACEP was critical in that they sent a board member to that meeting because Sandy Schneider thought it was important, and she knew there was a huge gap in terms of what was the care that was being delivered, because she herself was delivering the same care she had learned about in medical school, which was 25 years prior. And so she was curious. And that led to meetings, led to this organization, and then really has led to bringing resources together. You know, we don't have money per se, but just ideas, and really has been such a fruitful collaboration and dissemination of our ideas. And so that's how we got started. It was a patient and I guess a physician. But if you follow your passions, great things can happen. And then bring in your friends. And even if they're not your close friends yet, make them your close friends. And then incredible things can happen.
For me, I got started as a volunteer. I was asked to direct the summer camp for the kids with sickle cell disease. And I fell in love with them. They were the most resilient kids I had ever worked with. And I didn't know that much about sickle cell disease at the time. So I sat with Dr. Darlene Powers one night, who was our medical director, and all night listened to one of our kids crying and in pain. And she explained to me all of what sickle cell disease did and how it worked. And I just felt at that point, this is something that I need to keep doing. I love the outdoors, so being a part of an outdoor camp experience was something that was just a natural fit for me. And as I started working with the camp, I then took a part-time job at the foundation, which was then called the Sickle Cell Disease Research Foundation. Took a part-time job there. I was transitioning from elementary school teaching to trying to open a daycare program, and I got stuck. I got stuck in the foundation. And during that time, my sister married a man who had sickle cell disease. They have 3 children. He passed away in 2012. And the thing that I kept wondering about was, why is his care so much better than the care that the adults were receiving in California? Right before Wayne passed, it was Thanksgiving weekend, and he hadn't been sick enough for us to be concerned about anything about his care. But he said to me, he said, "Mary, don't forget about us adults." And I said, "Why would I do that?" He said, "Just don't. Don't forget about the adults." Then Trevor Thompson, a man that I worked with during my time with the SCDAA, said to me at a conversation we were just having, "Mary, don't forget about the adults." So I started with the little ones, and I've ended up in this area of helping and working with adults with sickle cell disease. And it's been a passion and a commitment of mine forever. So if anybody asks me what I do, I am first and foremost an advocate for people with sickle cell disease.
I'm just going to ditto because we're running out of time, but I volunteered for 25 years with the organization I was with. I'm from the South. I'm from Louisiana, so Louisiana, Missy Lou, right there on the border, Mississippi and Louisiana, Missy Lou. And I had a plethora of family members who had sickle cell disease, but like the young lady said from Nigeria, they didn't talk about it. So we didn't know what people were dying from. And so when you are born into it, I just was born into it, but became a better advocate when my son was born with trait, and then volunteered for 25 years. Originally, technically, I am an electrical engineer, a mathematician, minoring in statistics. And I became a federal grant writer. So I wrote the grants, and so they made me the treasurer. And I went from the treasurer to the board chair, and our director was teaching at HBCU, and she wanted tenure, and they said, you can't work anywhere else, you need to go, and the board said, you're going to run it, so you go run it, and so that's why I've been running it since, I think, 2015, but I've been there for years. So I learned every inch of that organization. I could tell you what's going on with my eyes closed because I was there doing the fundraisers, doing the camps, doing all the stuff, and writing grants. And I became a federal grant reviewer. And they were like, well, you go learn how to do that. So then you come back and write some grants, then you know what they really want. And so that's how I got there. And one thing I would say that when we started, our organization started, we did not have a national office. So we made sure, and I say a handful of us, a handful of them made sure that we had an organization under the great Charles Whitten, making sure that that there was someone to speak and do all that other stuff while we were boots on the ground taking care of our patients.
All right, thank you so much for this amazing panel. I'm in awe of what can happen when people come together and work together for individuals with sickle cell disease. And so thank you all for your attention. This has been really fun for me, and so I think we're moving along. Thank you so much.
Thank you, Amala. In the spirit of that very sentiment of the need for connections and community, we're making a change to the agenda. We are actually going to go on break now until 2:15. There's more coffee and cookies out to the right in the East Wing. And we challenge each and every one of you to come back by 2:15 with contact information for at least one new person. We'll see you back here in 15 minutes.
Produced by the U.S. Department of Health and Human Services.